There's no free healthcare. Someone has to pay for it.
So, for example, South Africa has enshrined access to health in their constitution.
Yeah.
So that means that no hospital can turn any patients, but whether they have money or not.
What we need is a blueprint for health.
Yes.
All right. And we say over the next 30 years as a country, this is where we want to be.
I think part of our problem in Africa is we've not been able to connect research to the industry.
Yes.
So we do a lot of basic research, and the incentive is not there for government to fund research.
Now imagine you want to go to a health facility and you go there and you find those that are named after a famous person, or one that is named after a saint, or one that is just named after the area. And you think to yourself, why isn't there one standard for naming these things? Are we going to answer that question? I'm not sure, but it might be answered because I have a panel of experts who are going to go into the broader picture as we look at health systems. Welcome to the MedSquard Podcast. Now imagine you want to go to a health facility and you go there and you find those that are named after a famous person, or one that is named after a saint, or one that is just named after the area. And you think to yourself, why isn't there one standard for naming these things? Are we going to answer that question? I'm not sure, but it might be answered because I have a panel of experts who are going to go into the broader picture as we look at health systems. Please introduce yourselves, gentlemen.
Yeah, my name is Anthony Ajayi. I'm a researcher at the African Population and Health Research Center, where I co-lead our work on adolescent sexual and reproductive health. But I must say, my PhD is on an assessment of free healthcare program in Nigeria. So I get to understand some of the health system dynamics that we'll be talking about today.
Oh, yes. Wow. This is going to be exciting.
My name is Theuri, Dr. Tim Theuri. I'm a trained dental surgeon. That's where I started. Currently leading Kenya Healthcare Federation. We are the umbrella body for all the business member organizations who are not government in health, and we take care of the entire value chain for the sector. I also sit as a board member at the Kenya Medical Practitioners and Dentists Council, where we are the regulator for the sector. And those two jobs pay for my other two jobs, where I'm a husband and a dad.
Which are the most important jobs? Those ones. Yeah. So now, you both mentioned health systems, and of course there's the policy level and then also the end user side. But what is included when we say health systems? How far do we go? How broad is it?
I think for me, it's when you say health systems, they're trying to do one simple thing, and that is optimize the relationship between the person who's seeking care and where they're seeking it from. All right. So that relationship between a patient, if I may use those words, and a doctor or a clinician or a nurse, that's the relationship that is being optimized by what you're calling the systems behind that front. And I don't want to say the people who are coming to seek care, and I've been one of them, we usually don't care what's happening behind there at that particular moment. We just want things to work. So it's the entire system behind that. The healthcare workers, the systems that enable them to work, the places they work, the policies that allow that to happen, regulations, law. It's that. If I'm to simplify, that's how I'd put it.
Okay. Yeah. So if you are to break it down, even whether it's levels or practically, because that could apply globally. Yeah. But if we put it practically, like whether it's in Nigeria or in Kenya or Uganda, are there levels that we can point at and say, okay, this is where I fit in?
All right. I think yes. Care has been categorized with complexity. So with perhaps maybe a level 1 facility, if I may say so, level 1 service. Walk-in, simple things can be done. A simple lab test maybe, and then escalate to the next level of care where more complex things are available. Imaging begins to get available at that point, and then now I think you begin to get the cascade as you go up to where you have super specialist facilities, which are now level 6 for a case in the country. Centers like Mathare for mental health. We do have facilities, if I may use Aga Khan, Karen Hospital as examples of where they're categorized as level 6 facilities. Kenyatta is one of them. So we expect when you get to a level 6 facility, whatever specialist or subspecialist care you need, it should be available there. Yeah. Gertrude's Hospital for Children.
Yes.
Yeah.
Okay.
Yeah.
So when we look at health systems, for us, there's the whole issue of there's cost, accessibility, and all. And this phrase keeps being thrown out. Doesn't matter whether it's in the US or in Europe, but universal healthcare. From your experience, is it achievable?
Now, that's a very interesting question. It's a question I've always thought to myself that it should be an aspirational goal, even if we don't have resources to provide healthcare for everyone currently. It's just like debate around universal basic income. Is it attainable? The government have resources to provide income for everyone.
Yeah.
But everyone needs income. So maybe we don't have money for that currently, but there should be some effort towards that. So you will see some countries, say for example, South Africa, has enshrined access to health in their constitution.
Yeah.
So it then means that no hospital can turn any patients back, whether they have money or not, which is something brilliant about South Africa.
Yeah.
If South Africa can do it, and they've been doing that since 1994 with the new government, when apartheid ended, then other countries should aspire to that. Because for me, no one should have to fall sick and not be able to go to clinic because they don't have money. Or no one should have to, go into debts, medical debts, because of an illness. So for me, governments can, and there are examples of countries that already do that. UK has NHS, Sweden, quite a number of countries have actually demonstrated that it's possible. It's something we can do. Can we do it in Africa? Of course, South Africa is already doing it. Even Botswana and a number of countries already guaranteeing access to health care for everyone. So other countries can definitely follow, to my mind.
Now, with countries like South Africa, people point to the recency of either colonization of being or gaining independence. And so now comparing the UK and Sweden, so people will say the reason they have that is because of how recently they got, well, should I say independence or broke away. Does that have, does that play in anyone's mind? We're talking about traditional, African countries that have either had a longer period of independence and the ones who are more recent. So is that something that is propaganda or is it something that is real in terms of our culture and the way we approach maintenance of systems?
I'll be very honest. I'll speak from my heart. I've always questioned whether we've wanted it hard enough, all right, for us to do it, all right? Everything else we wanted hard enough has been done.
Yes.
When we're looking at defense spending and the vehicles that carry the bosses, or the guns that protect them, we go for best in class, all right?
Yeah.
But for healthcare, we do have conversations. We are a resource limited setting. Let's start here before we get there. But the other sectors, we are going for best in class. So we should just want it hard enough, and it's going to happen. A couple of things that we may want to think about. You see, just like he said, is aspirational.
Yeah.
And there are two ways of going about it. Ensure the population is earning lots of it so that is not an issue.
Yes.
Or if that's an issue, we ensure that the baseline is taken care of. There is no free healthcare.
Yeah.
Someone has to pay for it. So we decide who is paying for what and up to what level they can pay, and we ensure that the base is okay. Because at Independence, we strived to do three things: tackle poverty, illiteracy, and disease. Those three things still are with us, though at varying levels for varying sections of the population, but they're still with us. So I think it's now the decade that we sort out healthcare. We've done pretty well with education. We introduced it very stepwise. We say there's going to be free primary public education.
Yeah.
And then after that, we say there's going to be free day secondary education. And then now we said, okay, let's bring on the borders as well. So even for health, it's stepwise. Stepwise. Now conversation on healthcare financing is happening through the Social Health Authority. After that, we will need to decide how we're transmitting the data in the system.
Yes.
Then after that, now it will go now to things like commodities, that is drugs and whatnot.
Yeah.
Yep.
Hey. Yes.
Maybe to add to that, and then talking about the how colonialism affects our health policies. South Africa is a very good case study. You know, after decades of being excluded, after decades of falling sick and not having access to healthcare. So when they gained independence, I would say in 1994, it's one of the things they had to put in the constitution to ensure that all the suffering of the past do not repeat itself under a black leadership. So maybe colonialism do play a role. Maybe it's not propaganda after all.
That's a relief. That's a relief. Now, when we come back on the MedSquad podcast, we'll be looking at some of the challenges in depth to do with health systems. You know, when there is a saying that goes, the devil is in the details. There's a twist to that I'm going to show you when we get back. Hey there! Welcome to Theuri Health HQ, where Africa's finest medical minds meet modern care. I'm Yafesi, your host on the MedSquad.
Care is personal. It's not just diagnosis, it's direction. From a cough to managing chronic illness, we listen and we lead.
Every symptom has a story. We listen, explain, and act together.
Nutrition is not just about food. It's fuel, it's healing, it's prevention. We help you eat with purpose, for energy, for recovery, and for lifelong health.
We are not just lab coats, we are detectives, and your blood speaks and it translates.
Your mental health is not a luxury, it's your health, period. Whether it's trauma, depression, anxiety, or even wanting to speak to someone, we are here for you.
At Theuri Health, collaboration is our strongest prescription. We connect expertise across Africa to deliver care that is smart, affordable, and people first.
This is the MedSquad. Real conversations, real health, real people. From your inbox to your bedside, we're with you. Welcome back to the MedSquad podcast. Now, remember earlier I said the devil is in the details. What about the devolution is in the details? So I want to talk about some of the challenges with health systems. Of course, there's the institutional and policy framework. But what are some of the major ones? You talked about funding. That one is not straightforward. But what are the other challenges that health systems face? And in doing that, you could also touch on whether there was any marked improvement or otherwise when devolution was implemented.
I'll start with the last question. There's definitely been improvement because right now we do have services across the entire country.
Yes.
Something that never happened before. We have an image intensifier in Isiolo. So this is a piece of equipment that helps you when you're in theater to see whether you fixed the bone properly or not.
Yes.
Right? That was not there before. We do have cancer centers, some as far out as Garissa. And we were there when it was being launched. So yes, the answer is yes. I will touch on 4 things. That's the money,
Yes.
the people, the infrastructure,
Yes.
and then leadership and governance. All right. On the money, we get our money from 4 main wallets. And then government, I'll split it into 2. That's the national government, the county government as well. We do have money that comes from donors. And then now we call what we have out-of-pocket expenditure. And out-of-pocket expenditure, we do have private underwriters. And I'll begin with this budget cycle. There was a back and forth between National Assembly and Senate where they were saying we need more money for counties.
Yes.
They've given, I think, 395. They wanted, I think, 450. Settled somewhere in between, I think, 405 or 415 billion. Out of that money, half of it is going to health. All right?
Okay.
Half of our money that goes to county goes to health. And perhaps half of that is going into human resource or rather recurrent expenditure. So it's a good thing more money is going down, but it's also going down in such a skewed way. Yeah. Now, the other one was the people. Health is a shared function. Some will say it's fully devolved. That's their debate. But the people are now at county level. So there's a conversation of how do we advance their studies? Are they being paid on time? There's an issue of when collective bargaining agreements are signed with unions, there'll be a need for for stepping up salaries, yet the physical space is not expanding at an equivalent rate or at a similar rate.
Yeah.
So that is also a big challenge that is there. Ideally, we should have teams of workers where, say, for example, if it's the team that deals with the heart, maybe the brain, we have a doctor, a nurse, maybe a pharmacist as part of that team, so that we don't only train one person and that person is working in isolation because the rest of his team is not trained or the rest of her team is not trained. Infrastructure, health is heavy on equipment, is heavy on buildings. And these are things that we don't do because of return on investment. We do them because in the long run, they are cost effective.
Yes.
All right. So like
imaging.
So if I have imaging equipment, it means that I can arrest certain diseases pretty early.
Yes.
And the impact of treating them from a cost point of view becomes effective.
Yes.
Much as the equipment initially is heavy to acquire in terms of cost.
Yes.
So there's a difference between cost effective and cost saving. All right. So in health, it may not necessarily be cost saving.
Yes.
But in the long run, it's cost effective.
Yes.
The aim here of, I think, any governor or any president is to have a population that is healthy for longer.
Yes.
And that is what we are aiming at. And finally, on leadership and governance, we do have a 5-year election cycle. And my honest observation is that this really affects how we're delivering health. Your face will come and say, I want to be governor.
Yes.
You'll do a nice poster. And then tomorrow, after 5 years, it will be him. And he'll want to undo all the work you've done because perhaps you're coming from opposite sides of the the political divide.
Why are you doing this to me?
Yeah. What we need is a blueprint for health.
Yes.
All right. And we say over the next 30 years as a country, this is where we want to be. And now we will score a face as a governor, depending on how much acreage is able to cover on the blueprint.
Yes.
So those are the 4 things that, in my opinion, have been a challenge, but therein also is an opportunity. If those 4 things are to be sorted out, health will be okay.
Wow.
Yeah, I think in addition to that, we're also hemorrhaging health workers, nurses, doctors, at large number. Where if you go to the UK, you'll probably see the African is actually playing a major role in the NHS. Whereas we ourselves, we have shortages.
Very shortage.
And again, in many states, like so for example in Nigeria, they just lack human resources for health. We have very few doctors.
Yeah.
And then you wonder, do people survive in those states? They depend on our local apps and things like that. And before they even get to the hospital, they're already dying. So we need to fix that as well. We need to find a way to retain our medical practitioners here on the continent, because we do need them here in Africa.
You know how lucrative it used to be back in the day. This one studying medicine, everyone is like, wow. But nowadays, it's not as lucrative, is it? I mean, we know there's the frustration of some systems not working. There are doctors who are without jobs and all. So do we start it from, like, collectively, collaboratively? The government can even set a target. So we're looking for this many doctors for this reason, for this many specialists in this area for this reason. So like now, as hemorrhaging doctors, and in some cases, it's also the end result of a mental health journey. For some of them, it can be a bit tragic. But is there an area like where you feel a serious gap? So there are doctors who might either quit or they just decide, you know what, I'm doing something else. But is there an area where you feel the gap, you feel the gap?
I mean, the gap is everywhere. I don't think there's one area we can say we are sufficient, we have more than enough. But even more so, if you look at mental health practitioner, if you live in a rural area, you probably need to travel house before you can, access a practitioner if you're suffering from mental health challenges. It's really more pronounced in that sense. That would probably be one area I would say we have so much shortage. And for me, someone said something that to improve all of these, we also need to grow the economy.
Yes.
Because if our economy is not growing, if we are growing at 1%, 2% negative growth, then we can't retain more doctors. So we need to improve the economy.
Yeah.
And unfortunately, our politicians are not doing a good job at that.
Now, with brilliant minds like yours, if you come forth with the brains that you have and your high IQ level, and you have a vision, you can conduct some research. It could yield a cure for cancer. It could yield a vaccine that has been elusive. Do you feel that like there will be support? Is there a support framework where you can say, this is what I'm doing, and the government comes behind you and says, yes, let's be the leader in this?
Yes, there are cases where government has really done its best to champion those causes.
Yeah.
HIV, tuberculosis, malaria, vaccines. Yeah. And when the pandemic came, of course, it took a leading role with a lot of support from the private sector. So yes, for those ones, they've done a good job. The second question behind that is sustainability. All right. Government is not in the business of doing business.
Yes.
All right. And as we speak right now, we've had a stable shilling over the last 1 year. Last month, for the first time, we have a single-digit base rate by CBK. Those things, government has done well, and they've done them with the help of the private sector. Good shilling in terms of forex against the dollar, good interest rates, but health, before you begin to attract investors, there's a certain predictability that is needed. One, tax regime. We've not had a stable tax regime. So year in, year out, haggling on the changes. And some changes do not protect the sector as they're building other sectors. So for instance, refrigeration panels in the last budget attracted an excess duty on them. And it did not differentiate between farmer grade refrigeration panels and non-farmer. So they all were slapped with the same rate. So we need to, as we're implementing our policies, think end to end. And just talk with the experts. This knowledge is here with us.
When you say farmer grade fridges, these are the ones like for vaccines and things like that.
So in the pharmaceutical factory where we make our medicines, there are panels that are used. All right, just to ensure that we have good sanitation. How else do I put it? Basically a sterile environment. Because you can't ingest drugs that are not clean. So those panels were categorized in the same category as refrigeration panels.
So those are the non-farmer. For meat.
So they were all categorized together. All right. The ones that are used in a cold room to line there. So those ones and the farmer grade ones were categorized together, and that was very detrimental to our pharmaceutical manufacturers. The other thing is, when money comes into health, it needs to behave very different than in other sectors in terms of the cost of acquiring that money and the tenure of credit. That is, how long am I required to pay this money in a manner that makes sense to the lender and to the person receiving the money. On average, you're looking at about maybe anywhere between 12.5 to maybe 15 years before we can say ROI is being realized. That is return on investment. So it needs very patient capital. It needs cost-effective capital again. Now, when you look at the banking sector, the financial services sector, and the Nairobi Stock Exchange, the top 7 companies are all in the financial services sector. And the difference of number 1 and number 2 is maybe 5 or 6 times. Number 1 being Safaricom, and then the rest are banks. They are contributing perhaps 33% GDP, but only employing less than 5%. Okay? So the story here is, if our banks were to only operate 3 days and just have their money in government paper, they'd still make their money. They don't need us. All right? So how about as a people, we can obligate them and have a conversation of, let us invest in health. Maybe obligate 2 or 3% of your book value to be in health. Because even for them, they want people to be healthy enough to borrow money and pay.
Yes. Yes.
So it shouldn't be a cycle that is only predatory.
Yeah.
But it should also be a cycle that enables the growth of the economy.
Yes.
And the top 6 or the top 7 people, whereas they are contributing immensely into the economy, if you look at their position in the debt cycle, it tells you where the money is.
Yeah.
Yeah. So the money is not on the output side.
Yes.
It generally tends to be on the input side of the debt cycle.
Aha. This is the in terms of now research, and is research something that's really an how do I say proactive thing that we do in Africa, or is it reactive? Because that discouragement is real. If I decide I have a moment to think, let me sort out malaria. I have a moment to think, let me sort out something I've personally experienced that I feel can be. That support is, that's what I'm wondering, is because we have the Kenyan example, we have a few pockets here and there, but when it comes, even when you had said how difficult it is to implement universal healthcare. So even as you touch on that research, the initiatives that you may want to take, with the existing things, because you're balancing a lot, can you also touch on R&D, and now when you want to do new development or new initiatives? So, yes.
Yeah, I mean, research is important. Most of the breakthrough over the years, when we started with research, might be basic research that has no immediate use, but often it's addition to such research that leads to breakthrough. I think part of our problem in Africa is we've not been able to connect research to the industry.
Yes.
So we do a lot of basic research, and the incentive is not there for government to fund research because they see, oh, you want me to put money in research? Fine. Put some money. Then what's the return on investment for the research? And as a politician, these are political decisions. So you are there, you fund the research, but then how do you tell the people that this is actually what I'm doing for the people? We do research, that research is our business. We need to be able to collaborate with the private sector and begin to see some benefit of this research in terms of products. If we're able to do that, then we probably don't need to persuade government to put money in research. Currently, Africa is about 10% of the world's population currently.
Yes.
And we produce only 1% of global research. So our output is really, really small currently.
Yeah.
And even the 1% we produce, I would say maybe 95% of the funding is coming from outside Africa.
Yeah.
So we still haven't given enough priority to research on the continent. I wouldn't blame governments completely for it. We researchers also need to do research that can benefit the private sector, because of course, private sector can also put money in research if they do see the benefits.
Yes.
And that's what we really need to do.
All right. Now, when we come back, we'll be talking about perceptions that could be killing us. Right here on the MedSquad Podcast. Welcome back to the MedSquad Podcast. You're with me, Yafes Msoke, and I have Dr. Ajayi and Dr. Theuri. Yes, two of the most brilliant minds that I've sat in between. I mean, I don't get around much, so so want to talk about how when it comes to health systems, there's public versus private, and in some countries, the word public is something that people, they celebrate, they cherish, whether it's public schools, the public health, or the facilities. And then private is looked down on a bit or felt to be inferior. Is that the situation we have here? Or is it like, you said public, anyway?
Yeah. So I'll introduce a new perspective. Yeah? We don't have a public or a private patient, right? The person who's seeking care is like when we started the conversation, they only want one outcome.
Yes.
To come in. The ultimate goal is to get better.
Yes.
Perhaps have some drugs if you need them.
Yes.
imaging if you need it, and maybe a lab test if you need it. All right. So that is what any person aspires to have when they are not feeling well.
Yeah.
And I'll roll you back to a small lesson in history. When we were convinced civilizations began, is when we saw someone in an archaeology site having had a healing bone, all right, a bone that had healed.
Yeah.
So it meant that someone went out of their way to take care of this person. This person never had to go for hunting and all those things until they got better.
Yes.
All right. So such is, if I'm to distill it to a very simple way, that is what healthcare is all about. Whether it is owned by the government, whether it is owned by non-government people, both for profit and not for profit, the ultimate goal is, are people getting better?
Yeah.
All right. If they are getting better, then I am okay. If it's on the non-state actor side, and it is for profit or not for profit, it has to be within a responsible business environment. All right? We can't have predatory behavior in health. Profits are good. All right? It's what you do with them, that is either good or bad. All right? And the reason I say that is because health was categorized in the last assessment cycle as the 6th fastest growing supported service sector at 6.7%. We did have in last year, as per the economic survey, maybe 115,000 beds. The parity is 50-50, government, non-government.
Yeah.
All right. If you look at the difference between that and the year before that, which is 100,000 in the year before that, the 15,000 beds, you can take a guess where they've been added. It's largely on the non-state side. All right. Again, the public sector has been known to deliver healthcare at scale. Private sector, again, is the competitive advantages on quality and consistency of care. So if those two were to be merged, what else would we need? Yeah? If we merge the scale of government and the consistency and quality of the private sector side, then I think it doesn't get as perfect a scenario as that. Yeah.
Wow.
Yeah, I'd like to add to that. So for me, building trust is really important. I'd said earlier that my PhD was an assessment of a healthcare program, the free healthcare program by the government. And what I found is really profound in one sense. So there are middle to upper class women that are not going to even consider using the primary healthcare system at all.
Okay.
The quality is not up to the level they want.
Yes.
And then there are the lower middle to poor people that depend solely on it because that's the only thing they can afford.
Yeah.
So for me, irrespective of where you are across the social structure, you deserve quality healthcare.
Yes.
And that's really important. So as we are trying to build infrastructure, improve the human resource, it's also important that the healthcare itself is of good quality. What does good quality mean?
Yes.
It simply means that the waiting time is short enough. You know, if I'm sick and I consider it emergency enough for me to leave my house to go to the clinic, I don't want to spend the whole day before seeing a doctor, for example. I don't want to spend the whole day before getting medication to address my illness.
Yes.
And that's one measure of quality. It's also important that the way you are spoken to by the practitioner, it's respectful, it's professional.
Yes.
So you don't want a condescending attitude because I look unkept, so I'm probably not rich or poor, you know.
Yeah.
In Africa of today, when you are rich, you dress well, you park your big car, you get treated
Different.
Very different. Yeah.
We need to address poor quality of care.
Yes.
But you see, one surprising finding for me as well is even the poor people are satisfied with what the rich people would not even touch at all. They are happy because at least they have their needs met.
Yes.
How much more if we can improve on the quality in the primary health system, because that's why most of the problem is. I think in the cities where you have the tertiary health care, they can compete with the private sector. I would believe in most countries, the tertiary system can compete with the private sector. They have all the practitioners. In fact, the practitioners are practicing in these tertiary healthcare system are also the one you meet in the private sector. Often to you, same doctor. So they are professional. They provide the quality care, but the healthcare that the poor people depend on, the primary care system, we need to take it seriously on the continent of Africa.
Yeah.
Because, for most people in the rural area, they don't have access to Aga Khan of this world, except they are probably dying and the family is able to transfer them to Nairobi. However, the healthcare system in their rural area, we don't need to abandon it.
Yes.
We've seen situations whereby government, have abandoned the primary healthcare system. If we allowed the building to grow bushes without even any health practitioner, and some had to close down. And that should not be happening. We need to invest at the lower level, and that's really, really key.
All right. So to close this out, I give you each $1 billion. What's the first thing you do? I mean, you don't have to finish all of it in one go, and don't buy shoes. But what's the first thing you're doing with regard to health systems?
After paying tax.
After paying tax, you be as responsible as you want to.
I think it begins and ends at the community level. So I would want an initiative that takes care of primary healthcare end to end. All right, such that you don't have to know any big person at that level for care to happen to you. Okay, that must be something that we take care of as a society. And the aim here is to remove the indignity that people face when they're seeking care because they can't afford it, and give them financial protection in a sustainable way. I would want to say that it should also support laws that enable that to happen. And then finally, I would also ensure that it's in a fund of sorts that we are able to live off it as a healthcare sector in a way that it will be used for a very long time. So it will be a case of more money for health and more health for the money. Yeah.
Hey, okay. So I've given you $1 billion. You still have yours. He's used some of his.
Yeah, for me, I think I agree with him. It's important to invest at the community level.
Yeah.
We need to take healthcare to everyone. And that includes building infrastructure in the communities. And then ensuring that there are commodities in those facilities.
Yeah.
People should not have to travel all the way to the city to seek basic healthcare. I think it's also important to spend some of the money on preventive healthcare so that we do not spend all the money on curing diseases.
Yeah.
There are so many diseases that we can prevent. So maybe a bit of program on raising awareness on lifestyle. I like what they are doing in the US, MAHA, Make America Healthy Again. Yeah, because if you have a population that's so sick, you're going to spend lots of money. But you see countries like Japan, they won't spend as much. They spend far less than the US.
Yes.
And they get far more results compared to the US that spend far more. So for me, preventive healthcare is also really important. People need to have information on how to take care of themselves. They need to know how to eat healthy, to exercise, and to generally have become healthy, because we have an epidemic of non-communicable diseases. Before there's a lot of focus on HIV. But HIV is killing far less people relative to non-communicable diseases like hypertension, stroke, and diabetes and all of those. And these are lifestyle diseases.
Yeah.
So it's important that people are aware of how to prevent some of these diseases by changing their lifestyle. So a bit of program on preventing diseases would also be what I'll spend the money on.
All right. And with the change that you've left over, I'm going to buy some more imaging machines. But it's okay. So, to whom it may concern, remember one thing. Numbers don't get sick. It's people who do. So make health systems human. If anything on this podcast has helped you or you found useful, or you wanted to show off to your friends the brilliant knowledge that is available here, please share the podcast and follow us on all our socials at the MedSquad Pod. We'll see you next time.